pulmonary hypertension. I certainly would like to thank PHA Canada for this opportunity to have this session, and certainly thank them for organizing this great virtual event. We have about 60 minutes and we have a lovely panel put together. We decided to kind of organize about 20 minutes around some topics, and then I've really left the rest open as a question and answer session for the group. So first I'd like to introduce the panel just so you have an idea who's with us today. We have really some nice representation from across the country. Unfortunately, Dr. Anne Fournier was not able to join us because she had completed a French session of equivalence yesterday. But from Toronto, we have from the Sick Kids Hospital, we have both Dr. Luke Mertens and Dr. Andrea Dragulescu, who are certainly the leaders of the Pediatric Pulmonary Hypertension program at the Sick Kids Hospital. From Stollery Children's Hospital at Edmonton, we have Dr. Angela Bates, and then myself from the Calgary program. I'll work as the moderator today, as Darren mentioned, so certainly please send your questions and comments along in the chat box, and I'll do my best to fit them in as we go along through the discussion. So pediatric pulmonary hypertension for us really is a very exciting to work in, as there's lots of new therapies that are evolving, but there's still lots of unanswered questions. Although we collaborate a lot with our adult colleagues in research in pulmonary hypertension, there really is some growing amount of pediatric specific research that's being done. As part of the pediatric PH medical community, we all aim to be part of research, as we really do feel it helps improve pediatric pulmonary hypertension care. So our first topic we were going to go into is talking about pulmonary arterial hypertension medications. This is also an exciting topic as there's always many changes every year. I'd like to highlight, certainly for the group, as you all know, pulmonary hypertension medication funding is different in every province. And it's just important to highlight that, as it might affect the decision-making and practices between pulmonary hypertension programs. Celexa, one of the newest agents for pulmonary hypertension management, is the one that we wanted to talk about first. For those that may not be familiar with this medication, it's part of the same drug family as Remodulin and Flolan, but it can be given as a pill by mouth. It's been used with good results in adult pulmonary hypertension patients, and so it's become more available for us to use in pediatric patients. So our first question to Dr. Mertens and Dr. Dragulescu, can you describe your experience with the use of Celexa in pediatric patients with pulmonary hypertension?
Yeah, I think we've been using it as an add-on treatment, and we started using it as the third option. So in escalating therapy, we've become more aggressive in starting with dual therapy in patients who are presenting with severe pulmonary hypertension, and rapidly escalating to a third therapy. Having the option of an oral treatment definitely is very attractive instead of going through subcutaneous or intravenous treatments. So having Celexa as a third option definitely is very attractive from that perspective. Our experience so far has been that because we started it in kids who have more advanced disease, is that our feeling is, but it's a feeling, and we definitely need the studies. And I know that Dr. Bates has also some experience he will probably be willing to share, is that the response is variable. And sometimes it works and it adds some additional benefit, but our experience has been that after some time we had to switch over to subcutaneous Remodulin, where you could see an additional beneficial effect on top of the Celexa. So we still need to investigate whether there's a place for this drug earlier on in treatment. Because the adult trials is always a mixed bag of patients who started on relatively early on while they are relatively asymptomatic, versus patients who have more advanced disease. And I think we've been using it, and I don't know what your experience is, Angela, but we have been using it in the more advanced stages, and probably there's a place for it in the earlier stages, but we will have to investigate that. But I'll let you share your experience with the medication.
Yeah, hi everyone. So yeah, no, I mean, we've been using it, both Dr. Voorhees and I out west here, as well as the same experience out east, is that we really weren't sure where it had its role, but certainly was very exciting. And lots of patients were really eager to either avoid going on to subcutaneous or IV therapy or to actually wean off. Um, our experience has been that the patients that have had more advanced disease and we've tried to wean off of Remodulin haven't really been that successful. And part of the problem might be that the tolerance of the medication at that point might not be as well tolerated. You might not get the same absorption, or maybe you just need higher drug levels than you're able to absorb. The other aspect is that it isn't quite the same as the prostacyclin. It's an a receptor agonist. So it's a little bit different in whether it has the same remodeling properties or anti-inflammatory properties. I think we're still learning. So I really see it as a role of being a bit more aggressive with oral therapy. Just as Dr. Mertens mentioned, we're being more aggressive earlier on with even dual therapy, and maybe there's a role for being a little bit more aggressive with oral therapy with a third agent, especially in patients that have a BMPR2 or something that we know the disease might be a bit more aggressive. But I think it's a nice option to have for patients where either they don't tolerate subcutaneous infusions for, behavioral reasons that they won't actually allow the sites, or maybe they react to the sites, or patients that really for quality of life aspects are not interested in going down the subcutaneous road. We've also used in some of the Eisenmenger's patients because it's a bit tricky in terms of titrating pulmonary vasodilator therapy. So I think there is a role. I think in pediatrics, we're just still learning about that. And the other thing that makes it a bit tricky is the dosing, because we don't actually know. We extrapolate from adult data and sort of say this is roughly about what we need for pediatric patients, but that what we call pharmacokinetic and data is still being looked at. And there's some pediatric studies that will be coming out probably in the next few years to help guide us. And then I think lastly is the dosing. We can only get such a small form. We have split pills, and it's obviously not recommended by the company because they can't reassure us that we get the exact amount in that medication if we split pills. But as you guys know, we do what we have to do. So that makes it a bit more challenging too to dose in the younger kids. So I certainly think it's really promising, but I think just as Dr. Martin said, I think it's going to have a role maybe earlier on in being a bit more aggressive with therapy. But I think we'll have to reevaluate in the next 5 years. And hopefully as we start to pool our experience, but also get some of the trials results to help guide us, then we can help to guide you guys a little bit more with your children and how we can use drugs in their care.
Great. Thanks to both of you for your insights on the use of Celexa. Certainly an exciting addition to our options for medication therapies. Moving on to another medication, I wanted to talk a little bit about riociguat, and I'll put Dr. Bates on the spot for that because we've had some cases that we've shared there. And Dr. Bates, can you tell us a little bit about riociguat and your experience with it?
Yeah, so I'm not sure if any of you guys have heard about riociguat. So Adempas is the other name, and I know the States has had a little bit more, it's become a little bit more available, especially in the adult world in the States, but it acts on the same pathway as the nitric oxide pathway. So the same as your sildenafil, tadalafil, but it acts at a different place. So what we do is our bodies they produce nitric oxide, and that helps the vessels of the pulmonary arteries to relax. And the way it works is eventually it produces this little molecule that tells the muscles of the pulmonary arteries to relax. And so earlier on in the pathway, you can actually stimulate more production by stimulating an enzyme called guanylate cyclase, and riociguat does that. So you can't use it in combination safely with other PDE5 inhibitors, so sildenafil, tadalafil, because your patients will get really low blood pressure. So you have to switch it out. And so and there's more adult literature that supports the use in both the group 1 disease, so the idiopathic, the hereditary, and the ones that are associated with congenital heart disease, but as well as CTEPH, which thankfully is really not very common in kids. So we actually had a patient that we were having difficulty managing her disease, and she had CTEPH, and she's quite little. And so we decided we would try riociguat, and it was difficult to get approval for, but because of the adult literature, and there was some pediatric case studies to help guide us, we were able to get successful funding. And so it's a bit tricky because most of our kids wouldn't get started on it. You would be already on a PDE5 inhibitor. So we had to flip her from tadalafil to sildenafil, and then slowly do a conversion to riociguat and watch the blood pressure really closely. Tolerated the medication very well, but again, dosing in kids is a little bit limited. It is a 3-time-a-day dosing, so it's a little bit less convenient than our once-a-day tadalafil. And in terms of side effects, very similar to a lot of other vasodilators, but one of the other things to watch for is anemia. So of course, we're very careful to have our kids on good iron supplements, and we always want to make sure that they have the best level of hemoglobin. So that can be a bit of a challenge. So that's been our major experience. We've thought about it in a few other children, but we haven't trialed it yet. Some of the case studies have really been in more advanced disease and they've had good success. But again, I think we still need to know more information about what the use is in our pediatric population. And there is a study called the Patent Child Study that is looking at the use of riociguat in children with PH. So I think hopefully we'll have some information, but it might not be for a few more years. But you might see us think about it in certain situations, depending on the type of pH your kids has, or whether they have an intolerance to one of the PD5 inhibitors.
Great. Wonderful. Thanks for your insights on that. Another exciting medication that may have a role in the care of our pediatric patients. I wanted to move on to Remodulin. Certainly, it's a drug that many in the group may have had some experience with in terms of the care of your children. Remodulin, for those that aren't as familiar, it's a pulmonary arterial hypertension medication that's delivered really by either an IV pump or a subcutaneous pump. It can be very helpful therapy, but it's also very challenging, as many in the group know. There have been some innovative ideas recently to improve the quality of life and the delivery for those patients that are on a Remodulin infusion. There's an adult research study currently looking at the use of an implantable pump for Remodulin delivery that is now hoping to extend to include older children. An implantable pump would avoid the need for patients to carry a pump to deliver the Remodulin and potentially reduce troublesome things like central line troubles, site reactions, and infections. There's also been some neat work done to create a new formulation of Remodulin that's called ProDrug or RemoPro. This new version of Remodulin, just to introduce it again to the group, is designed to be an inactive drug in the subcutaneous tissue, but it gets activated once it hits the blood. So it's broken down at the blood level, thereby decreasing things like site pain for those patients that are on this formulation of subcutaneous Remodulin. Certainly another new and exciting idea in terms of improving Remodulin care. Unfortunately, right now, none of these innovative ideas are ready for pediatric use in Canada. I wondered if anybody on the panel wanted to add or elaborate on the discussion of these two emerging ideas for the delivery of Remodulin therapy.
Yeah, go ahead, Luke.
Yeah, I think the system so far is not even been FDA approved. I think it looks very, the implantable pump. I mean, I think it's not FDA approved. It's going to take a lot of time, I think, before it's going to be approved in Canada. There's been some. The latest release from the company was that there's there will be some delays on the approval because they got a response from FDA, so they probably will have to make some changes in the device before it will be approved. But obviously, that would be something that would be a potential good alternative to the current subcutaneous administration with the external pump, which can be challenging in daily life and definitely as it challenges. And would be a potential good alternative for administering the drug. Definitely, we'll have to await the results of the trials and the safety of the device, the complications that are associated with it, and we'll have to see. But definitely for the bigger kids, I don't expect that to be used in smaller kids because the device is quite big. So it's probably only going to be available for adolescents, I would say above 14, 15 years of age. Angela, I don't know.
Yeah, I think that I think it's really exciting that the world of, because we know our patients are quite rare, but it's really great that we have companies that are really invested on trying to move forward and make our patients' quality of life, including pediatric patients, but as good as it can be. I think it's really promising. I think there's going to be a delay, and COVID slowed everything down in all aspects of research outside of COVID. So I know Spain, I was just looking to see what the latest, and there was a a recent case study that was done on 3 patients or adolescents that had the implantable device placed, and it's early experience. So they didn't really talk about a lot of the complications after being at home. It was more the initiation of the device and the tolerance of the device. And of course, these are bigger kids. So I think some of the things, I think it sounds ideally like it could be really useful in kids that are really stable on therapy, that are a good size. We do have baclofen pumps that really quite skinny kids that end up having a lot of, they are on baclofen for spastic type things. So they do tolerate an implantable pump. But I think, they have a lot of experience and a lot of knowledge. Our kids are a little bit different in that we do titrate up the medication quite frequently. We're always worried if all of a sudden the medication isn't working. For baclofen pumps, it's more, they get, the pain and the spasticity worsens. But for us, if our kids aren't getting delivery of medication, that can actually have some significant consequences. So I think we'd have to do a little bit more teasing out of the bugs before we can actually use in our patients. But I suspect, just as you mentioned, Dr. Mertens and Dr. Rory, it'll be really adolescent population that will be using it first. And then once we get, and hopefully from there, maybe there'll be an incentive to make smaller devices that can fit into the abdomens of smaller children. I think the prodrug is really probably more feasible right now to be thinking about our pediatric patients. So because a lot of our kids, although it's annoying to have a site, and of course, our families, as you guys know, I don't have to say it to you, as parents, are very creative. And how do you get a swim in between site changes, or a bath, or things like that, or water protective, water sleeves for going out in the water, things like that. But from a pain point of view, I think the prodrug really hopefully can improve just the tolerance of the medication. And as a lot of our kids get really apprehensive and anxious about site changes because of the pain. And so if we can actually start a site and have very minimal pain right from the get-go, I think that will make it a lot more tolerant as kids get older. So my money's on that for the future, for the immediate future, and then hopefully the implantable pump kind of further out. And then there's a lot of exciting things that, people are talking about in terms of even other therapies, outside of our module, things like gene therapy and stuff. So I think it's an exciting time to be in PH, and I think we'll have to see where that heads, and maybe we'll alleviate the need for all of the earlier, use of even prostacyclin therapy in kids. But again, all of this is, I think, 5 to 10 years from down the road, I think.
Great. I agree. It is an exciting time. And although these are still sitting on the horizon, it's nice to have some new ideas sitting on the horizon to improve the care and quality of life for the patients that we follow. And I imagine certainly as parents, exciting to hear about some of these ideas for the future. I thought we just changed gears now. I'm just going to check the chat box. Certainly, it sounds like no questions or comments about those topics, but certainly as we go along, please, for the people in the group, don't feel shy to throw in your comments in the chat. We're happy to build them into the discussion as we go along. We'll change gears and talk a little bit about devices and interventional changes that we've seen in the field over the last few years. The topic that I thought we'd touch on is atrial flow restriction devices, which are certainly some new devices used in pulmonary hypertension. I wondered if Dr. Mertens or Dr. Dragulescu, whether you would be able to describe the role for us of an atrial flow restriction device, a little bit about what it is and why we might consider it in the use in pediatrics with pulmonary hypertension.
Sure, I'm happy to take that one. I think yes, atrial flow restriction devices have been used, and there are some indication. I think for children, I see two main indication. One, in children that have fairly large ASDs that have volume overload on top of irreversible pulmonary hypertension, in which we would attempt to put a fenestrated device in to control the amount of left to right shunting while keeping the potential of right to left shunting in case of need. So that would be one case scenario. And then another case scenario in patients with idiopathic pulmonary hypertension that do not have a shunt, to create one and implant a device in order to maintain that atrial communication that was created, to maintain it open, because it has been shown that at the expense of some desaturation, having an atrial shunt can improve survival, can improve quality of life, can improve exercise tolerance. So I think these are the two scenarios where we would consider using these atrial flow restriction devices. So one way to control the amount of left-to-right shunting in a larger ASD, and in the other one to create one for a pop-off for the possibility of right-to-left shunting to maintain cardiac output at the expense of desaturation.
Great, thank you. I know certainly it's something both in the East and the West that we've been considering more often for certainly the indications that you've very nicely described. I just wondered if you and Dr. Mertens would like to talk a little bit about your experience with the use of these in your program.
Yeah, we've implanted a few, especially for ASDs, to restrict the flow, and I think it's still very early to say kind of what the potential disadvantage is in these patients, and I think if you look at, because I gave a presentation is in this conference about what's published on it right now, and definitely we'll need some more data to prove that it's actually beneficial. So that's where I think we'll need to. Because implantation of those devices is always a big decision, because any procedure you do in patients with significant pulmonary hypertension always a risk. So you have to carefully balance the potential advantage of doing a procedure like this versus the potential risk associated with the procedure. So that's always a delicate balance for us to, and it's always a difficult decision that's made together with the families in conversation with the patients and families to discuss the potential advantages, disadvantages. Also be honest about that we don't really have clear evidence right now. I think the guidelines are still confusing. The European guidelines, they clearly define the use of those devices and came up with clear recommendations of when you should use them. In North America, it's still open because they've not been officially approved. So we use them a bit off-label right now. Not a bit, they use them off-label. Yeah.
Yeah, no, thank you to both of you. Off-label use, unfortunately, is something that we have to have some comfort with in the pediatric practice for caring for patients with pulmonary hypertension. I wonder if we just change to another gears to another intervention, and it's something called the reverse pot shunt. And I know certainly many families have probably heard a little bit about it. The reverse pot shunt, it's another intervention that we've been using a bit more frequently in the past few years. And again, still, like Dr. Mertens had mentioned, it's still something we're using rarely as we're figuring it out. But it's certainly something that I think is worthwhile just introducing for those that may have heard only a bit about it, so that they can have a bit more knowledge around what it is. There's also an active registry right now helping us to learn a little bit more about how to best use the reverse pot shunt, as well as its timing. I wonder, Dr. Bates, if you could describe briefly about what the reverse pot shunt is, and when we might consider the use of a reverse pot shunt in a patient with pulmonary hypertension in the pediatric world.
Sure. So yeah, pot shunt, we always refer to as pot shunt, but it's really when Dr. Voorhees refers to it as a reverse pot shunt. The original indication from it was many years ago. It was actually a way for cyanotic hearts to actually provide pulmonary blood flow. So we were actually trying to get blood flow from the big vessel that comes out of the heart, the aorta, to actually give blood to the lungs in patients that were born without really good pulmonary blood flow. It was sort of a palliative strategy. And then, that type of surgery had gone by the wayside after there were newer surgeries for those types of patients. But as our kids were getting, and even adults were getting sicker without something in between therapy and waiting for a lung transplant, people were thinking, well, how can we actually protect that right side of the heart, which was getting into trouble? And so, someone was very astutely thought, well, what if we use the pot shunt in a reverse way? So what it does is it actually is a little connection. So there's two different ways to do it, surgically and transcatheter, but a little surgical shunt so that blood that's coming out of the right ventricle, going into the pulmonary arteries, there's a lot of resistance to that flow. And so instead of the RV having to really struggle and pump against that flow, there's a little pop off typically between the LPA, the left pulmonary artery, and then the descending part of the aorta. And so you are able to kind of pop off that flow from your pulmonary artery, allow the right ventricle to not have to work so hard. And so you do get a little bit of blue blood that goes to the lower part of the body, but you maintain good oxygenated blood to the brain and to the heart, which is good. And it allows the heart to just not go into failure early on. It certainly has bought us a lot of time in pediatric patients. There's been some adult patients it's been used on as well. And I think most of our patients can actually be done just through an incision on kind of the left side of the chest. And so avoiding any type of bypass and just being done in the OR by very experienced surgeons. And so the other type of way to do it is some people have actually gotten really slick at doing it through a catheter approach. So just like your kids would go for a cardiac cath, they would do that same approach, but it's a much more skilled way of placing a shunt between that left pulmonary artery and the descending aorta. That experience is still a little bit limited, and I think there's more information we need on that, but it's certainly something that may be more available as we get more experienced. But in terms of indications for our kids, really we've been using it a little bit more and more when we get to advancing our triple therapy with Remodulin, and we get to a point where that right heart is really starting to struggle and patients aren't growing as well. They're limited by their activity limitations. And, but they're either, we're trying to bridge to a lung transplant, or they're quite little to list for transplanting and parents are really wanting something in between. And the really interesting thing is the timing of it, because you want to do it before the right heart really gets in trouble, but not too early that you might actually get blood flow that goes backwards and forwards across that putt shunt and puts more stress on the pulmonary artery system. And it is a surgical procedure, so there are risks with it, although the data that's coming out of the registry is patients that we've really thought a lot about and done it electively, there's been 0% mortality. So patients have been very, very sick. There's still a risk of death. It's very small, but it's still there. So we have to think about it very seriously. Some people have actually suggested the pot shunt might even forego going down the road of Remodulin therapy first. I think that's, again, still very early to say. We know that the pot shunt doesn't change the course of disease, so you're still going to need Remodulin at some point in time, but some people suggest it might buy you some time. Our center hasn't done that approach yet. We've gone down the road of doing augmenting triple therapy, and then once we've sort of gotten to a point where we think on top of that we need some support for that right heart, we've went down the pot shunt road. We've had really good success. We have a really great surgical program, as does sick kids. So I think that's part of it, is that you need surgeons that are really experienced and invested. But it's something that at least gives us some time and really has improved quality of life for the kids that have had that done. There's some question about, it doesn't forego having to go down the transplant road at some point. But hopefully we can get kids to grow taller and bigger and get to adulthood before we're thinking about that, about having to go down the lung transplant. And there has been successful lung transplants done in those kids with pot shunts. It's a little bit trickier in terms of bleeding risk, but it has been done. And so again, hopefully we'll get a little bit more experienced in that setting, especially now that we have the registry pooling our information, so that we can guide us to make better decisions for our patients in the future.
Great, thanks, and Dr. Bates, for that. Certainly that's a challenging topic, and both the use of the atrial flow restriction devices and the pot shunt are certainly both things that we have to really think carefully about when we consider them in the care of pediatric patients. I wanted to move on now. We're about halfway through our time, and just wanted to certainly thank the panel first for their insights on the questions that we talked about so far, and now wanted to open up the floor to the audience for questions. As Darren had previously mentioned, certainly we are a small session today, so certainly if you're comfortable, feel free to unmute yourself and ask your question. If not, please place your questions in the chat, and I'm happy to direct them towards the panelists.
Or even sharing experience. We would love to hear your guys' experience if you guys have had any experience with anything we've talked about so far.
Well, while you guys are thinking about your questions or comments, certainly I can keep the panelists going with more questions. Just a couple of questions as we go along, just another totally different topic. Moving to exercise. Exercise is certainly a an interesting and certainly a very important topic in the care of all our patients, especially certainly as we know there's growing rates of childhood obesity. I think certainly talking about exercise is very important for any patients that are cared for with a chronic illness. So just wanted to put out to the group, wanted to get your thoughts on how you approach exercise with your patients with pediatric pulmonary hypertension, and if there are any particularly recommendations that you provide families, any restrictions to activity, and also maybe if there's any sort of exercise prescriptions or recommendations that you provide for the patients that you care for.
That's definitely a developing field, and I think like in every pediatric disease right now, and certainly for pediatric heart disease in general, the importance of exercise has been discovered, rediscovered during, I think, the last 10 years, I would say. We are actively developing and re-looking at how we recommend exercise and what's the position of exercise in children. Historically, I think the pediatric cardiology community has put children with heart disease on restrictions. And I think the good news is that we have discovered that was a very bad idea over the years, that we overestimated the risk for children and that we actually may expose them to a risk of not doing enough physical activity. And a healthy lifestyle for any disease you have is definitely important. That includes patients with pulmonary hypertension. And a healthy lifestyle is within the limitations of what you can do. And recognizing what your exercise ability is, and then try to participate in physical activity within those limitations is something we recommend. We're building an exercise medicine program right now, and we're working on integrating the pulmonary hypertension program within that program as well, so to try to activate our children better, which can contribute, I think, to a maintenance of their overall well-being. And but we'll need to collect the evidence for that. I think it's perfectly safe to do that within the limitations of what kids can do, and that there may be a long-term benefit of with the treatments we currently offer as an additional treatment. And definitely, I think what we try to avoid is that there's too much inactivity.
Yeah, I have to completely agree with Dr. Martens. I think that thankfully, I think people are realizing that limiting our children is actually can actually even cause harm, mostly because, well, one, we know that physical activity helps with mental health, which is huge in our patients. This is a chronic illness. This is something they have to deal with their entire lives. And so that's one benefit from it. The second thing, obviously, is that our kids are still going to be prone to getting, they can still get, not prone to it, they can still get coronary artery disease, they can still get all the other things. And certainly being overweight doesn't help in terms of, risk of obstructive sleep apnea, things like that. But then the other thing is that the conditioning of our patients is huge, especially because we do know this is a disease that progresses, and keeping our children to be the best candidate they can be as they move into adulthood, and especially if they progress towards a lung transplant, is very important. And then there's actually a lot more literature that actually supports that exercise improves the production of nitric oxide. It helps to attenuate the right ventricular hypertrophy that occurs, and that really self-limiting activity is what we should be recommending our patients to do. So we do avoid things that make like a bell style maneuver, we call it, so where you bear down, anything where you're doing heavy weightlifting or heavy rowing or really fast bursts of running, things like that. But otherwise, really they should pay attention to how their heart feels, how their work of breathing feels, that they don't get any chest pain, things like that. And so ideally, we'd have an exercise program for all of our children, and the adult world does have exercise programs. So I think Sick Kids is a bit ahead of us, but at the Stollery at least, and I think Erica, probably for you guys as well at in children's, we've gotten some teenagers into the adult world, but from a pediatric point of view, we're still working at developing an actual exercise program. We do get some ability to do cardiopulmonary exercise testing, which can help us to understand how far advanced a patient's disease is, as well as how they're responding to therapy, but can also give us an idea about how safe they are. It's not necessarily indicated for that, but you can definitely get an idea. And so we can reassure you guys that your children are safe to exercise. So often I recommend to patients that they should initially start exercising slow. We kind of work with them to do a kind of a titrated exercise program, and then we do it in a safe environment. So we get them to exercise with family members or exercise at a gym. Lots of kids have Fitbits, and you can argue how accurate they are, but they do give you a bit of an indication. And so that's kind of how we've approached it at the Stollery until we get a formal exercise program developed for the cardiac world.
Great.
Yeah, I think having them exercise in a safe environment, as you said, is very important. And I had several conversations with quite a few of the patients saying, okay, well, my dad doesn't exercise. I said, okay, well, make it a family thing. Go together for walks, go together with the bikes, get involved the whole family. It's important for everyone, not just for you, but okay, make it, presenting it lightly, but reinforcing it every time at every visit. So how much are you doing now? How is it going? Try to push a little bit as much as you can. Go every day. Do. It's very important to do. Reinforcing that over and over and over again. It's I think it gets to them in the end, and it definitely helps in the long term.
Great. Well, thank you for all of you for your thoughts. Exercise certainly is important for all of us. And it sounds like certainly our programs are unified in our approaches in terms of encouraging exercise in a safe environment and getting some resources to help kids be able to make those steps forward. So we don't have any questions yet, so I'm going to keep giving our panelists some more questions to work on as we wait. But certainly, again, as for those in the room, if you have questions, want to ask or add them to the chat, please feel free to. Another topic that comes up often in the clinics, of which certainly all of us are very fortunate to work in multidisciplinary clinics that include not only physicians and nursing, but also includes dietitians and exercise and physiotherapy, all these people that work with our patients. Another question that often comes up is about nutrition, and certainly a question that can be asked to many, particularly new patients with pulmonary hypertension that may not have been growing so well around their time of diagnosis, is what can we do to optimize their nutrition? And just wanted to chat a little bit about that amongst the group and see what suggestions certainly the different multidisciplinary teams at our centers have been using to help promote nutrition in pediatric pulmonary hypertension patients.
I can speak from the Stollery point of view. So I think one of the biggest challenges a lot of our parents have said to us is that they feel like they've met with a dietitian, and because their kids weren't growing well, mostly because their disease was either poorly defined in the beginning, or we had poor control, or there was probably another reason why they weren't growing well. They felt like they were being made to feel bad that their kids weren't getting nutrition, which is not the intention of the nutrition team seeing them, but that's how they perceive that. And so I think what I've tried to work on with parents is that for me, it's important to understand what are the caloric needs that your children has and why. Maybe it's the fact that we just actually don't have good enough control of the disease right now, because that's a huge part of what we call our functional classification is, are children growing well? If their hearts are working so hard that they're using all their calories to do that, or they're breathing so hard, those kids that have lung disease as well, they won't grow. They'll put all of their energy into that aspect. So it's actually a marker for us to know how kids are doing. Some of our kids have syndromes and they don't grow as well for other reasons. But what we've really worked at doing with our dietitians is working with the family to figure out, okay, what sort of nutritious food can we help, basically maximizing your family instead of just putting in extra fat into things, which was our parents' complaints. But we've actually started to look at using the role of a metabolic cart. We haven't been able to use it in our outpatient setting because of COVID, but certainly in the inpatient setting, we've been able to use it. It kind of gives us an idea of how many calories does your child burn? It's actually amazing sometimes how many calories our kids are burning sitting there doing nothing. So getting an idea of really, just so that you can visually see that, hey, it's not that I'm doing anything wrong. My kid's just burning a lot of calories. So, and then working at, okay, what sort of things can we do? Are there different ways of using, nutritional supplements, et cetera. But even things like macronutrients and things like, vitamin D, the role of iron supplements, but how can we creatively get it into the kids' diet so they don't get GI upset, things like that. Managing reflux, if that's part of it. And then other things we think about is preventing constipation, as we talked about, having to bear down is not safe for our patients. So we've tried to work at it more as a sort of a holistic approach with our team. And we actually have 2 dedicated dietitians, one inpatients and one outpatients, that works with our cardiac program, that have really been invested in our kids. And I find that they're really starting to screen kids early on and then work with the families and meet them where they're at, instead of put a prescription at the family. So most of our families have found that more useful. Again, I think we're still learning about what are the best diets for kids with PH. And I think one of the other interesting research avenues that we're actually going to be looking at in our center is just, there's been some research that suggests that ketones actually are helpful in the inflammation of pulmonary arteries, but it's difficult to get with a ketone diet. You can't just do it with a ketone diet because you get bad things as well, like fatty acids. So, but looking at, whether our kids' levels are actually abnormal. And so I think we might see more research in the adult and pediatric world coming down the pipeline that might guide us in terms of what sort of foods are even better for our kids. But I think we still don't know enough about that other than just getting good nutrition into our children.
I agree with that. I think, definitely it's a multidisciplinary approach with a dietitian to try to optimize calorie intake and supplements if necessary. I think at the other end of the spectrum, it's also sometimes weight control, and because especially when you're more limited in exercise. In exercise capacity, and you do less physical activity, obesity can be an issue, especially in the adolescent age group and the young adult age group. So that's another important discussion to have and work with the team to try to prevent and try to work around that.
I think that's actually a really important point that you bring up, Dr. Mertens, because I think, often we are so used to pumping our kids full of calories, but we have the opposite problem. And actually, I often say to families, I think it has to be a family lifestyle approach. I mean, we should all be doing a better job, let's be honest, about eating well balanced and exercising. But really, it's like when a child in your household is diagnosed with diabetes, you have to sort of modify your nutritional intake. It really is important to have a healthy weight balance. And so, which is always tricky, I think, when kids that are limited with their activity. But I think
that's where our exercise medicine program is more a lifestyle program. So we look at diet, we look at physical activity, look at sleep as well, which is also very important. So it's a more integrated lifestyle approach, and that's something I think that will need to be further developed, because I really believe that that can significantly also improve quality of life for children with chronic diseases, to optimize that environment where the kids live in.
Yeah. No, and also certainly we always have to work around some of the side effects from the medications that we're using. That's often the other question that comes up about optimizing diet and timing of how do we optimize the timing so those symptoms might improve through the day. I just had certainly a great question from the crowd here that I'll put through to the panelists. And the question is, how do hormones or pubertal changes affect medication choices? And I may even extend the question as well as what kind of changes might we expect in terms of pulmonary vascular disease around the time of puberty?
That's a very good question. I think regarding the hormonal change, we actually don't know. And because there's no systematic studies on the impact of hormonal changes on metabolism of drugs. It's definitely a concern. If you think about that, we will have to get that knowledge, and that's where hopefully when we get more multi-center studies where we have both boys and girls included going through adolescence on the medication and see whether there are significant changes during puberty. Definitely that period in life of your accelerated growth, where you grow a lot, is a challenging period because there's a lot of changes in the body that affect the circulation, and that's definitely a period where you have to watch carefully what's happening with the disease, because the the circulation may be limited in pumping enough blood into the bigger body. And that's where sometimes intensification of therapy may be needed, and definitely careful follow-up to know what your experience is, Dr. Bates.
Yeah, no, I 100% agree with you. And I think exactly like you say, we still don't really know. I do think probably growth has something to do with it. And I don't think we fully understand, and whether the hormonal changes play a part, I don't know. But we certainly have seen patients that have progressed into disease around that period of time. We always have to think about, teenagers are a bit more responsible with their medication. So, I mean, most of our patients are very compliant with their meds. So I don't think that's an issue in most cases, but certainly something we think about. But maybe their metabolism of drugs changes over a quick period of time. I think we still don't really know. One of the questions about hormones, though, I think that's interesting is for girls, as girls hit menses and they start having their period, we think about, so one, they can, a lot of our drugs cause dysfunction of the platelets and they do get prolonged menses, but also two, when they have those prolonged menses, it's harder to keep your iron levels up and harder to keep your hemoglobin up. And so for a lot of those reasons, and then that confounded with the fact that some girls get really bad, menstrual cramps and things like that, that already if you're feeling kind of crummy and then you've got a site to worry about with Remodulin, the last thing you want to do is have all of that complicating things. So we've often linked our females up with an adolescent gynecologist. We have a couple here, and I think Erica, I know you guys do too. I'm sure you guys have great people with sick kids as well that really can help our teenage girls work on what sort of options you have. And we still try to avoid estrogen-based birth control pills because there's still enough question about whether that can cause more harm than good. So mostly progesterone only, or IUDs that are progesterone only that can be used. And again, those are bigger conversation topics, but there are different things that we can do to manage that we know are safe, that we don't even have to worry about driving the process. And then of course, there's always the topic of pregnancy, which we can't ignore. We have teenagers, and teenagers can get pregnant. So, and how that can, how you have to think about that in teenage girls. But in terms of just hormones in and of themselves, I think, just as you mentioned, Dr. Martins, I think we are still not sure. Kids are going to go through puberty. It is actually encouraging though when kids hit puberty, because if kids that are not doing well, that have chronic illnesses, their puberty is delayed. So the fact that you can have a child that all of a sudden does hit puberty with a chronic illness is sometimes, strangely enough, actually a milestone. So it does help us to understand a little bit how they're doing, but hopefully we'll get more information as we pool all of our data, even just nationally a little bit more, to get a better idea of how that affects our kids.
Great. Well, certainly that's a big topic, puberty, and not only in the medical world, but also in your families. So certainly the other piece I just wanted to add in, there's been some great points that are brought up. Puberty not only has changes in terms of the body, but in terms of the mental state. And certainly many of the programs here, I know sick kids in Edmonton as well, bring in often the use of psychologists and at that puberty change, only because that's certainly a big time where lots of kids go through some big questions about how do you move on and how does life look living with a chronic illness as a teenager. So I certainly those are all pieces that fit in around that time where life is changing for these kids, and they're moving on to ask big questions as they move into the adolescent world. So I haven't had any other questions that have come through the group. So, and I think we just actually have 1 or 2 more minutes. So instead of getting our panelists into a deeper discussion on a new topic, I thought I'd just give another minute or two for the audience. If there's any other questions or comments, give you the opportunity to have a free mic. Good. Well, I think certainly I wanted to thank the panelists, and there's some nice thank yous coming through in the chat as well to the group for everybody's discussion and insights today. It's really been a pleasure to be here today. Again, a big thank you to PHA Canada for setting this up. Wanted to certainly encourage everybody. I think there's one additional session today, the plenary session that's coming on. Darren will fill us in on I believe, which is on new and emerging research in general in adult pediatric, or sorry, my apologies, adult pulmonary hypertension. So certainly I hope today's session's been helpful and everybody's gained some nice insight, and been a pleasure to have you all with us today.
Yeah, and thank you to the panelists for taking your time out of your what has probably been a very crazy summer and busy schedule to do this for our community. Thank you everyone for coming. And I hope everyone had a great week, a great session. As you know, Dr. Voorhees said, that the closing plenary is in about 45 minutes. It is translated, so it's bilingual. There's a panel of doctors coming, and it's on, you know, new and emerging research in pulmonary hypertension. So it should be a good time. And the site's still open, so please explore all the chats and the discussion groups and the art galleries. And if you have other questions or you wanted to kind of talk to our panelists, send a message to PHA Canada and we can forward through and kind of get you the information you need. And thank you very much.
Thank you.
Thank you.
Thanks, everyone. Have a great day.
Have a great
Bye.
day. Bye.